Getting a compounded estrogen does not make it safer, more tailored, or more effective. I'm Dr. Laura Pfeiffer, naturopathic doctor and Menopause Society certified practitioner. And one of the things that I'm talking to my patients in perimenopause and menopause about all day is hormone replacement therapy. What is the best option for them? How do we measure success? And how do we know that what we're doing is truly individualized to your needs? As a naturopathic doctor, I feel like I have a unique perspective of how to create treatment that is tailored to your needs. We look at the root cause, we look at individualization. And a lot of what we're doing is diet, lifestyle, and supplements, but prescriptions are no different. A lot of what I see on the internet is people talking about how they've gotten these compounded, individualized prescriptions, and a lot of practitioners make it seem as though if we get things compounded, we are being more individualized than if you were to get a prescription from your doctor for the products that are available for estrogen, for example. And that is just simply not true. Not only does it do the patient a disservice because they are potentially paying more for their prescriptions, but also we're doing unnecessary testing in a lot of these cases. I've seen practitioners online say, well, we need to do a Dutch test or we need to do blood work to check your levels. And patients are really drawn into that because they think, wow, I know nothing about perimenopause. I'm not understanding my body because we don't talk about it enough. And when we do, a lot of doctors are uneducated on what needs to happen next, how to identify perimenopause, and it leads to a lot of confusion and a lot of patients feeling dismissed. So they come across these functional providers who are offering what feels like this insight, this unique insight. We're going to look at your hormone levels and we're going to tell you exactly where you are. And then we're going to compound a unique prescription to your specific needs, and it's going to be perfect. I want to tell you why that's a problem and why, as a naturopathic doctor, I absolutely prioritize looking at the root cause and providing individualized care, but why I also don't feel that we need to test your hormones and give you a compounded prescription. So here's the thing. When identifying perimenopause or menopause, the STRAW criteria has us look at bleeding patterns. Now, I'm looking at a combination of bleeding patterns. Are they having irregular cycles? Are they missing days? Has the bleeding quality changed? And I'm combining that with where they're at in their age and stage. Statistically speaking, if you're over the age of 45 and you have symptoms of changing cycles, you're likely in perimenopause. So why don't we test your hormones? Because the reality is if we test your hormones, we're not getting any additional information than we had before. The problem is, when we are testing anything in medicine, we have to make sure that the test that we're doing is giving us unique insight into something that we didn't already know. So this is the same thing as if a patient brings me blood work and says, interpret this blood work. And I start asking them questions and they say, well, no, I'm just interested in you interpreting the blood work. Well, the thing is everything comes with context, right? And so I need to know information before I can easily interpret that blood work. When it comes to the menstrual cycle, we can't just randomly look at blood work and say, you're in perimenopause. And if we could, this conversation would be a lot easier than it is for a lot of people. The reality is there's no single identifier that tells us you're in perimenopause. We look at a combo of your symptoms, your age and stage, and your bleeding patterns. And if you've had a hysterectomy or an ablation, there are certain things we can do. But the reality is, if you have your ovaries and you've had a hysterectomy, you're likely still making hormones to some degree. Now, perimenopause is not that your hormones have dropped to a specific level or that your FSH is up at a specific level. It is the fluctuation in these hormones throughout the month that drives the majority of these symptoms. And so, testing your hormones may or may not be helpful. The other thing is, even in a woman who's premenopausal, who is cycling normally, we have to be very specific about the timing with which we get testing done if we are choosing to test at all. And so that requires another layer of conversation to understand when we would go and what we're looking for. And then we have to understand the idea that the menstrual cycle is complex and always changing. And so if we're getting a really good read on things, one time on a day, whatever, day 3 or 21 is still not really robust enough data for us to make really confident decisions, even in someone who has regular periods, even in someone who we don't think they're having wild fluctuations. They might be, but maybe we don't because they have a regular period and we're trying to identify other issues going on. And so even in someone who's regularly cycling, I'm not ideally, if I can help it, looking at hormones in a one-time snapshot. I'd prefer to look at hormones throughout a month, multiple times, whether we do that through urine or blood work, which tends to be more expensive and much more annoying to have to go to the lab multiple times in a month. But when it comes to perimenopause and menopause, you can understand now why this is tricky. Because HRT does not require a specific number. It also does not require for your estrogen to be gone. It doesn't require for your period to be gone for 12 months. In fact, we know that in a lot of circumstances, when we treat in that perimenopausal stage, when a woman is highly symptomatic, we're going to have the best outcomes for that. And so, when we're giving hormone replacement therapy, we go based on symptoms. Now, there are a number of standardized questionnaires that we can have someone fill out. We can get some objective data of what their symptoms are like. And also, one of the most important things that I find is overlooked in this conversation when we're thinking about individualizing things and tracking our outcomes and seeing how we get better is what else might be contributing to these symptoms. One thing we know for sure about perimenopause and menopause is the symptoms are vague. Other than hot flashes and night sweats, we have joint pain, brain fog, mood changes, bleeding changes, anxiety, depression, hair loss, hair growth, low libido, vaginal dryness. We have insomnia. We have itchy ears. We have things that you would have never thought. And so we do have to realize that a lot of other systems in your body can also contribute to these symptoms. So when we're looking at what we're supposed to do, what's the role of HRT, this is where my role as the naturopathic doctor comes in, because we can say, listen, we know that HRT is likely part of a layer. And some of my patients don't even want to be given HRT at first. They're like, well, let's just investigate, see what else is going on, and then we can map out our treatment plan plus or minus HRT and everything else. But we also want to look at nutrient deficiencies, thyroid issues, insulin resistance, inflammation, gut issues, all things that contribute to many, if not all of the symptoms that I just discussed. And so when I tell my patients I'm not testing your hormones, it's not because I'm not listening and don't want to individualize your care. It's because testing your hormones would not give me any additional information than I already had. And so if I don't need the information, there's no reason to test. There's nothing I'm going to be able to interpret from that. And anyone who tells you otherwise is wrong. I've seen many patients who will be on an HRT dose, get testing done by their provider, and their provider, as a result, tells them they need to reduce their dose when they really felt good on their dose. And in my opinion, that's doing the patient a disservice, because there's no number that tells us if someone should stay on or go down or go up. It's how do you feel? With a little piece over here about what else is going on. Because an unchecked, untreated insulin resistance, thyroid issue, low iron is not going to make you feel good on HRT, right? We have to make sure that we're treating the root causes. Now, onto the products themselves. I've yet to find a specific situation where compounding a product is required and appropriate. In fact, when we compound a product, a lot of patients do this under the impression that it is more natural, it is safer, and it is more individualized. That is just not true. We know that when we give estrogen on the skin, the products that we have available to us are all bioidentical, body identical. The dosing is more consistent because it's not made by a person at an individual pharmacy. And there are a lot of different dose ranges depending on the product that we choose. And we individualize that based on the patient's need. It's also more cost effective to use a product over the counter that we can get via prescription. When we have to compound something, it's usually costing the patient a lot more. And so we have to factor this into the conversation. But it doesn't mean that it's better. If somebody has an allergy to something in the product and we can't get them on the right dose, that is a reason to compound. If someone cannot get the right dose no matter what we do, that is a reason to compound. Otherwise, there are many products available that can be very helpful to fit our needs. And the last thing I'll talk about is progesterone. Patients will tell me, I need to test my progesterone. My progesterone's very low. Well, oftentimes that's the first thing to change. When we start going through perimenopause, we're less likely to ovulate every single month as we once did. And so as a result, we're not going to make progesterone, because the only way we can make progesterone is by ovulating. Ovulating, making a corpus luteum, producing progesterone. If we don't do that, we're not going to be making progesterone. And so we don't have to test that in order to treat. So if you have questions, please comment below. Let me know what else you want to hear or what myths you've been told about hormones or hormone replacement therapy.